Rapid sequence intubation is using a sedative and a paralytic to render a patient flaccid, apneic, and safe for intubation. It's a risky procedure. You're taking the patient's airway away from them and you're causing them to stop breathing. You're also giving meds that can cause the hemodynamically unstable patient to crash. And this is why it is mandatory to resuscitate the patient before you intubate them. But I think the whole resus before you intubate is going to be another topic for another video. First things first, you've got to prepare your equipment. There's nothing that screams amateur more than dropping a tube and going, oh crap, where's my syringe? Where's the tube holder? Take a minute to prepare your equipment. It will pay dividends and it's not going to cause your patient to get any worse. There is virtually no scenario where a patient will benefit by you just dropping a tube, doing the monkey skill, and not having the equipment set up. Remember, you're intubating a whole patient, not just a glottis. Now that you got your equipment prepared, you must position the patient. They must be ear to sternal notch. Don't just head tilt chin lift them like I see most people try and do in pre-hospital intubations. The ear canal, or the auditory opening, or the ear hole as I call it, must be at the level of the sternal notch. This will provide the most optimal view as it aligns the airway axes. And from experience, an easy way to do this in the ambulance is to simply put the stretcher in a semi-Fowler's position and then pad the head and shoulders so that ear to sternal notch position is achieved. Then you gotta pre-oxygenate them. 15 liters non-rebreather mask or BVM with the O2 cranked all the way up. Non-rebreather, much more preferred because the patient is taking the breaths themselves and you're going to cause gastric insufflation if you're bagging them, but do what you must to manage the patient. Also, add a nasal cannula at 15 liters per minute. Yes, you heard that correctly. It greatly increases the amount of oxygen that is delivered to the lungs, and you keep it on the patient until the intubation is complete. Even if they are apneic, they are still getting oxygenated via passive oxygenation. And pro tip, you need to use a conventional nasal cannula to do this. You can't use an end-tidal nasal capnography device to do this. You're striving to achieve nitrogen washout. The ambient air has 21% oxygen, 78% nitrogen, and 1% other gases like argon and some other shit. That means that inside the patient's lungs is going to only be 21% oxygen. You want to wash away all that 78% nitrogen and replace it with oxygen molecules. When you do this, in theory, you have more time to perform laryngoscopy. They say that it will give you up to 5 minutes of safe apneic time to use your laryngoscope and find the glottis and place the tube. Keep in mind, that's anesthesia textbook stuff. Yes, if you effectively pre-oxygenate the healthy and stable surgical patient who's getting an elective tonsillectomy or a boob job, then yeah, you'll probably have a good 5 minutes of time to perform laryngoscopy. You're probably not going to have that in the real world with the patients that we encounter because we know that the person who got into a car accident invariably drank 14 Coors Lights before they crashed, and the person who was shot 5 times wasn't NPO for 12 hours. No, they ate a quart of pork fried rice before they soaked up a bunch of rounds from a 9mm. And that's why pre-oxygenation is so freaking important. You want to maximize the patient's physiology and avoid any and all desaturations. Let's talk about drugs. First, pre-treatment drugs. We used to give lidocaine to the headbangers as the first drug we pushed. The theory, emphasis on the word theory, is that it would blunt an increase in intracranial pressure that happens when you jam a laryngoscope down the patient's throat. Most places don't do it anymore as there's really no data to support its use, but I'm sure some places out there still do it. Small kids, and by small kids I mean under 1 year of age, should get a dose of atropine. Atropine is a parasympathetic blocker. Tiny kids are crawling, toddling vagus nerves. You put a laryngoscope down their throat, and you may actually directly stimulate the vagus nerve and cause a parasympathetic response that is going to really drop their heart rate. Giving atropine before you insert a laryngoscope is a way to mitigate that vagal response. But in 99% of patients we're intubating, we're just giving them an induction dose and a paralytic. The induction dose comes first. There are many different options to use, but in our world, the most common, by far, are etomidate and ketamine. Both work extremely well. Some people have their preferences. I prefer ketamine, but the reality is that the data out there does not support one over the other. Both have their pluses and both have their minuses. The point of the induction agent is to sedate the patient. One, in order to chill them and make them docile for you to take over their airway, but two, to knock them out so they aren't aware that they are getting paralyzed by a paralytic that you're about to give them. Paralytics do jack squat to sedate the patient. If you give a patient a paralytic without sedation, they're going to be 100% aware of it, and it's terrorizing for them. This is why induction is crucial. The problem with induction is that it makes the patient feel better and it chills them out. While this is great and all, we want our patients to feel better. If their sympathetic response is the only thing that's keeping their blood pressure up and their cardiac output going to compensate for a hemodynamic collapse, you take away that sympathetic response with an induction agent and they're going to crash. And this is why you need to resusc the patient before you intubate them and arguably give a dose of your induction agent to the shocked patient. Once you push the induction agent, give it a full 60 seconds to take effect. And now it's time to push the paralytic. Paralytics act at the neuromuscular junction at the postsynaptic acetylcholine receptors and block skeletal muscle from being able to contract, rendering the patient virtually flaccid. There are two flavors, depolarizing and non-depolarizing neuromuscular blockers. Depolarizing agents are going to cause fasciculations before they take effect. The only depolarizing neuromuscular blocker out there is succinylcholine. The benefit with Sux is that it's rapid onset and it lasts 6 to 9 minutes. So if you can't manage the airway, it wears off pretty quickly. But that's a shitty reason to select an induction agent. You need to go in with the mindset that you have prepared the patient effectively and you are going to get the tube without failing. And if you can't drop a tube, you always have a rescue airway as a backup. Succinylcholine has a lot of complications. Chief among them is hyperkalemia because those contracting, fasciculating muscles are releasing potassium. Any renal players, burn patients after 24 hours, patients who have a wide complex rhythm with a history to support hyperkalemia or are on potassium-sparing diuretics. Sucks out the window, can't use it. Most places have moved to non-depolarizing paralytics. These don't cause fasciculations, and they don't cause a potassium release. Non-depolarizing paralytics last much longer than Sucks. These last 30 to 45 minutes. Remember, the paralytic does not sedate the patient. It looks like it, but it doesn't. They are fully aware, so again, to drive the point home, they've got to be sedated and analgesed. Also, it is a misconception that paralytics are what causes hypotension after intubation. That's going to be the induction sedative and the initiation of positive pressure ventilation that causes the hypotension, not the paralytic. And some authorities say that in the shocked patient, you should double the dose of paralytic to make sure that it hits the receptor appropriately. Once the patient's paralyzed, it's time to drop your tube. Maximize your first pass success, proper patient positioning, and use video laryngoscope and the bougie. The bougie is thin and easy to manipulate into the glottis. It's like the old throwing the hot dog down the hallway analogy. Unfortunately, there's some hate out there for the bougie. I don't need a bougie to intubate. This tends to come from fat boomer medics who feel the need to validate their delusional self-perception of awesomeness by not using a bougie. I don't get it. I use the bougie. I think I'm all right. Anyway, use the damn bougie. It won't make you less of a medic. Quite the contrary. Video laryngoscope increases first pass success. Bougie increases first pass success. Use them both, and it's really going to increase your first pass success. Okay, you drop your tube. Start ventilating. Don't too aggressively ventilate. See my ARDS video about that. Confirm tube placement. Using waveform capnography with end-tidal CO2 is the gold standard. We've all heard that a million times. Also, listen to lung sounds to make sure you didn't go right main stem, because that will cause atelectasis and dead space on the left side, which you don't want. And then you do post-intubation management. Remember, the non-depolarizing paralytics last up to 45 minutes. The induction agent lasts no more than 10 to 15 minutes at best. So you've got to be on top of making your patient comfortable and not aware that they are intubated. Everyone wants to reach for the sedative. Benzo, propofol, Precedex, whatever. And no, that's not the answer. Yes, sedation is very important and you should be giving it, but what these patients really need first is analgesia. Analgesia trumps sedation every time. Intubated patients try to pull their tubes out because they're uncomfortable. Sedation without good analgesia just chills the patient out so they don't look uncomfortable for you. They make you feel better, not the patient. They're still going to be in excruciating pain because benzos and prop don't do jack for pain. I can't tell you how many patients I've picked up from sending facilities that were tubed and only on propofol or Versed. What have they gotten for pain? Well, they're on propofol. They're doing fine. And while they look docile, assessing them closer, you see tears rolling from their eyes. So you give them some pain meds, you give them a little bit of fentanyl or ketamine or both, and you see those tears clear right up. Analgesia, very important. And that is a quick crash, no pun intended, course on rapid sequence intubation.